Welcome. Happy Thursday. It's nice to see you all. If you don't know me, let me introduce myself. I'm Jenny Higgins. I'm a professor, the Bissell Professor of Obstetrics and Gynecology of Reproductive Rights, Health, and Justice here in the department. I also direct the Division of Population and Reproductive Health, and I'm one of the MCs of today's event. Let me just remind us all why we're here. This is a place for the department as well as for the university and our surrounding community, where we really honor a focus on reproductive inequities and addressing those inequities. In part, we come here to learn because we always have more learning to do. In part, we come here to find belonging. If you have ever been personally affected by reproductive inequities or structural racism, transphobia, sexism, other things that have negatively affected your reproductive body. If you've ever treated patients who have negatively been affected by those things, you belong here. If you, like me, hold outrage and despair in this moment, you belong here. So I hope we can come here today to learn together and benefit from the amazing expertise of the folks who are going to be speaking with us, but also just to remind ourselves that we're not alone and we care a lot about overcoming the things that so negatively affect our world right now. Let me also just say a little bit about Dr. Sarto, for whom this symposium is now named. Many of you knew Dr. Sarto and know of her, but I think it's really important to just highlight a couple things about this remarkable person. So Dr. Sarto started and ended her career here. So she went to medical school and residency. She graduated from the OBGYN residency program here in 1963, went on to an illustrious career, but then came back in 1998 and devoted the rest of her career here until her death in 2024. So still very recent person in our world. Her commitment to research, patients, mentees, and the community we live in, all remarkable. As a physician, she treated many patients and delivered many babies. As a department chair, she mentored many students and residents. I was one of her mentees when I was a junior faculty member here. And also just its remarkable national voice for women's health and reproductive health. So if you didn't know this, that Office of Research on Women's Health at the NIH is because of Dr. Sarto's efforts. She also created and got NIH funding for the Health Disparities Research Scholars Program, an amazing postdoc program that started here in 2007 and has been continuously funded since. And we have some remarkable HDRS scholars in the audience with us today. Also, I love that she's had this impact on the department, not only certainly with the symposium in her name, but in an endowed chair that Dr. Tiffany Green holds, and that in the future others may hold to carry on her legacy. So I really love that she is still very much around and with our department every day. I also am really pleased, and you'll hear a little bit more about this in a moment, to mention the nonprofit she was very dedicated to here in Dane County. She was very committed to health education in our community and had established the Foundation for Neighborhood Health Education, which you'll hear a bit more about in just a few minutes. So before I pass it over to that group, I want to thank our planning committee for efforts to put this group together. Several folks throughout the day will introduce speakers, in part because we like to showcase the various work of our committee and also just show you some of the richness in our department. I want to also especially thank the folks who reviewed our brief and brilliant talks that you'll get to enjoy in a few minutes. And just a quick housekeeping reminder, if folks on Zoom have questions, go ahead and put them in the Q&A on Zoom, and folks will be moderating that to let us know when those come up. All right, so I want to just have my colleagues Breeze and Jeannie come up for just a minute, and I'll be introducing them, and then they're going to say a word about Health Ed Express. Hi, I'm so happy to see you. So I'm going to just read a little bit about them, and then they're going to talk for a moment or two, and then we're going to get to our brief and brilliant talks. Okay. So Health at Express is this foundation that has a great connection with our department and now has this incredible leadership with these two folks over here. So Breeze from Sarto is the president of the Foundation for Neighborhood Health Education, where she honors and advances the legacy of her mother, Dr. Sarto, a champion for health equity. Inspired by her mother's vision, Breeze brings over 5 years of nonprofit leadership and a deep commitment to the Dane County community. In addition to leading the foundation, she also serves as a development manager for the Latino Commission on AIDS and actively supports Health Ed's Express mission. So we're really glad she's here. And then her colleague, Jeannie Erickson. Jeannie brings experience and passion of healthcare, social work, and family support services to the role of executive director of the foundation. Erickson worked as a geriatric nurse for 25 years and considers education and dissemination of health information a pertinent job as an ongoing nursing role. She has been also, like many of us, trained in the protective factors of social determinants of health, right? So brings that model to this work. The synergy between education, social work, and family support services fuels the importance and mission of health literacy. So please join me in welcoming them and hearing a little bit about Health at Express today.
Good morning, everybody, and thank you to the UW OBGYN department for giving us the opportunity to speak about this. As she mentioned, I am one of Dr. Gloria Sarto's 4 daughters. It's really, truly an honor to be here at an event. I know she'd be thrilled that her name is being used to connect educators and healthcare professionals to better public health and health equity. If you knew her, and like mentioned earlier in remembering her work really centered around health equity, and she wanted to ensure everyone had access to healthcare and health education, regardless of their race, income status, where they lived. She really believed in that. So in 1984, she launched Health Express, a brightly colored mobile van that brought healthcare and education directly into Chicago's Cabrini Green neighborhood, where access to resources was limited. That's what that photo there is actually referencing. That was through the Northwestern University that she was able to put together this van and really take education and healthcare professionals into a neighborhood that lacked that. So she never forgot that. And up until, if you knew her into her late years, truly Health Ed Express and the Foundation for Neighborhood Health Education was and is her legacy project today that Jeannie and I are getting to lead. The vision is carried on, and our goal is to create a reiteration of the Health Express today called Health Ed Express in Dane County, which will be exactly the same, where it will be a mobile unit that is going to provide workshops, health resources, different access to information, making it easier for people to understand and be able to take control of their own health here in Dane County. We're working towards building a similar mobile unit that we'll be able to take out onto the streets. But until then, we're already putting the mission into action by helping people improve their lives with health literacy resources. We're currently doing that through three different avenues. We put together a curated resource library that covers topics from sun protection tips for kids to fall prevention tips for elders in your home. It's all online, but we also are out in the community actively at different wellness events and community events, distributing these health resources for free, of course, printing them, and also being able to have conversations with people in a non-judgmental, safe zone. As we know, sometimes medical care and health things can be a little bit daunting for people if they don't understand the information that they're given. So that's really where we're stepping in, is trying to break down those barriers and make it so people feel comfortable talking about their health, feel comfortable talking to those healthcare providers and folks like you. We also have an active newsletter that we are putting out, and all of this can be found if you scan the QR code here at the bottom on our main website. You'll find the resource library as well as the community calendar. And then also tonight, we are hosting our first fundraiser for the Foundation Health Ed Express. While it is free to attend, we are doing an online raffle right now. So we have a little card in the back next to the parking tickets that you can scan for information. We have great raffle prizes from local businesses like Inner Fire Yoga or a Better Body Massage. And you don't need to be present at the event tonight. It's all can be online, and all gifts can be mailed and shipped, and we'll reach out to the winner. But again, I'm so grateful for the opportunity to share with folks like you that really matter and are doing the work. And we are really working now to build our network and partnerships. So being able to share the information with people like you guys, and hopefully you guys can share out as well. I'll be here. Jeannie and I will both be here through the event. So feel free to ask us questions at the end, or again, you can find all our contact info on the website as well. Jeannie, any other?
No, just to say thank you for the opportunity for us to be here to, again, continue information about Dr. Gloria Sarto and her legacy. And just to remind everybody that October is Health Literacy Month. So a little extra little trivia for you. Thank you.
Thank you. All right, thanks all. Really, really great to have you all here. So we're going to move to our brief and brilliant talks. And to introduce our brief and brilliant speakers, I'm going to bring up my colleague Anastasia Doherty, one of our also fellow MCs. Let me tell you a little bit about her. She's a certified nurse midwife in the ASOG division, the Division of Academic Specialists in OBGYN. She's also a member of the Planning Committee and a longtime member of the Department's Social Impact and Belonging Committee. She's been here since 2018. And in 2024, she won the Department of OBGYN APP CNM Unsung Hero Award. So thanks to Anastasia, who's going to introduce our speakers. And I just wanted to remind you, but before she does, that we're asking people not to photograph or record during today's presentation. And here, I'll hand it over to Anastasia.
Thank you very much. I want to keep these introductions brief because I want to give our speakers plenty of time to speak. But I do want to remind people that this was a competition. We had submissions, and these were the 4 people that were chosen after a review. I know you'll all be really intrigued and have follow-up questions, but there isn't time for questions today. But everyone's contact information is on if you scan the program, you can get to that. You can look them up. They all happen to have UW addresses or contact information that I'm sure you can find. So our first speaker is Amulya Suresh. She is a 3rd-year medical student at UW with a bachelor's degree in genetics and genomics, and she has a certificate of excellence in stem cell science. The second is Rachel Pamazel. She is a PhD student in epidemiology at UW with a master's thesis exploring PFAS concentrations and associations to obesity in Wisconsin. The third person we have speaking is Tawalade Adekunle. She is a postdoc in Integrated Health Services and Outcomes, assistant professor in the UW Department of OB-GYN with a doctorate in health communication. And finally, Laura Hanks, who is a clinical obstetrician in our practice, an assistant professor, and the director of the UW Gender Affirming Care Clinic. With that, I'm going to have our first speaker come up and start.
Good morning, everyone. My name is Amulya, and I'm a medical student working with Dr. Elizabeth Corey and the research team at Aurora Sinai Medical Center in Milwaukee. Today, the project that I'm going to talk about explores how Rohingya refugee women experience pregnancy and birth in a healthcare system that often doesn't speak their language, both culturally or literally. So to start, the Rohingya are a Muslim ethnic minority from the Rakhine state in Myanmar, just west of Thailand, who face generations of persecution and displacement. About 1.5 to 2 million live worldwide, many still stateless in refugee camps. Milwaukee is home to about 3,000 Rohingya, the largest community in the US. Most spent years in camps in Bangladesh or Malaysia, arriving with low literacy, untreated trauma, and limited preventative care, factors that can strongly influence pregnancy and birth experiences. At Aurora Sinai, our OB team wanted to understand Rohingya women's birth experiences, not because it was failing necessarily, but to make it even better. So together, with interpreters and community partners, we asked the question, what is it like for a Rohingya refugee woman to give birth in a system that doesn't speak her language, both literally or culturally? We designed a quality improvement project at Aurora Sinai in downtown Milwaukee. Using a female healthcare trained Rohingya interpreter, we conducted semi-structured phone interviews with 24 foreign-born women who delivered between 2019 and 2023. Because Rohingya has no written script, all interviews had to be verbal only. We asked questions about care use, communication, and cultural preferences, and analyzed results with help from a biostatistician using thematic and sentiment analysis. Overall, participants described very positive relationships with their OB teams. Every woman felt comfortable speaking up and felt that her culture was respected. 88% relied on their OB team to receive trusted health information. But still, 71% said that their birth experience didn't fully meet expectations. But this was mainly due to surprise or uncertainty around procedures like epidurals or unexpected C-sections. Many expressed gratitude for their care while also noting moments like these of confusion. The most common barrier that we found was transportation, followed by language access and system navigation issues like scheduling or insurance. Others mentioned cost, childcare, or confusion about appointments as well. So this tells us that even with supportive providers, these practical barriers often make consistent care harder to get. Women strongly preferred female Rohingya interpreters, though these were not always available. And because the language has no written form, all communication had to be verbal. Some women also felt confused about procedures, especially epidurals, and also unsure when they could decline interventions or ask clarifying questions, showing that clarity and comfort are what build trust. When we analyzed tone, 80% of responses were positive, as you can see on the left here, using words like trust, joy, and gratitude. Women said things like, they took care of me like family. The remaining 20% reflected fear or loss of control, such as feeling pressured to accept an epidural or told to stay quiet during pain. These mixed emotions remind us that even good care can feel overwhelming without clear communication. This project shows that quality care means more than just access. It means understanding. Trauma, culture, and communication all shape the birth experience. Our next steps here are to create short verbal and video education tools in Rohingya explaining labor options, partner with community leaders to co-design them, and continue prioritizing modesty and interpreter access. Ultimately, belonging begins not with translation, but with listening. Thank you to Dr. Corey, our OB team, and especially the Rohingya mothers who shared their stories with us so generously.
Okay, good morning. My name is Rachel Pomazal. I am a fifth-year PhD candidate in the Department of Population Health Sciences, and today I'm delighted to present some preliminary results on environmental exposures and ovarian cancer risk. So ovarian cancer is the deadliest gynecological cancer according to the National Cancer Institute. We have some information about individual level risk factors for ovarian cancer, such as family history of disease, high BMI, nulliparity, and others. However, relatively little is known about environmental and social risk factors for ovarian cancer, or how the context in which people live are affecting ovarian cancer risk. As you can see in the figure on this slide, every individual is situated within their social, physical, and policy environments. And we know very little about how this might impact ovarian cancer risk and ovarian cancer health disparities. So to sort of fill this gap, the Environmental Justice Index, or EJI, was developed by the US CDC to combine social and environmental vulnerability indicators, or different dimensions of vulnerability, and is a convenient method to operationalize these social, physical, and policy environments. And that can help us understand these vulnerabilities within health research. The Environmental Justice Index is comprised of the social vulnerability, environmental burden, and health vulnerability modules, which are then split into domains. So for example, in the environmental burden module, there's a transportation domain, an air pollution domain, and others, and these are just sort of dimensions of that vulnerability. And then within the air pollution domain, for example, there are individual component indicators, which are the actual variables that we are measuring in the population. So things like particulate matter, the number of high ozone days above a regulatory threshold, and others. And so then these component indicators are standardized into percentiles and then aggregated at the domain and then module level, and then summed to return an overall EJI score. And each module is weighted the same. And in this study, since we're interested in an individual level health outcome, ovarian cancer risk, we did not utilize the health vulnerability module in accordance with the technical documentation from the EJI. So in this study, we were asking, are the EJI or its component indicators associated with ovarian cancer risk among Wisconsin Women's Health Study participants? And to answer this question, we utilized ovarian cancer data from the Wisconsin Women's Health Study. This is a case control study that was conducted from 1992 to 1995 and 1998 to 2001. And 592 ovarian cancer cases and 3,489 controls completed risk factor telephone interviews to participate. We then reconstructed EJI indicators for the decennial census year 1990 to make sure that the exposure was coming before the outcome, which was ovarian cancer diagnosis, and then mapped all participants to the census tract where they lived at the time of participation. And then we modeled the risk of ovarian cancer according to the overall EJI score, EJI domains, and component indicators using hierarchical logistic regression. So what did we find? For every 10% increase in census tract proximity to an airport, we found that there was a 6% higher ovarian cancer risk. Every additional high ozone day above the regulatory threshold was associated with 2% higher ovarian cancer risk. So every time there's an additional high ozone day in your census tract, that's 2% higher ovarian cancer risk. And finally, we found that a 10 percentile increase in overall air pollution exposure was associated with 3% higher ovarian cancer risk. We did not see any significant associations in the social vulnerability domain or in the EJI overall. Now, these are preliminary results, so please take that with a grain of salt, but this is not altogether surprising. Air pollution is associated with risks of several other cancer types, including breast cancer. And we know that airports emit a large mixture of contaminants into both air and water, including air pollution and endocrine disrupting compounds, which can impact ovarian cancer tumorigenesis. Air pollution and airport proximity might represent underappreciated ovarian cancer risk factors and opportunities to improve health disparities in this area. And our next steps on this project are replicating analyses to examine whether or not these same factors are associated with ovarian cancer mortality, and using other methods to further integrate the social and physical environment in health equity research. I would like to thank all of my co-authors and all of the Wisconsin Women's Health Study participants, and all of you for being here. Thank you.
Good morning, everyone. I'm really honored to be here with you all today. I recently joined the department, and I'm excited to share this project on community-based organizations' perspectives on structural racism and systemic failures' impact on Black birthing people. So when we think about maternal health, the broader maternal health landscape, we often consider the perspectives of patients, of course, clinicians, midwives, doulas, but very infrequently or not frequently enough do we consider the perspectives of community-based organizations. However, these are really critical constituents for Black maternal health. And the reason for that is because they both have this sort of micro level perspective in their everyday interactions with Black birthing people. But then at the same time, they also have a broader, wider perspective into the landscape because they're engaging with other organizations, sometimes engaging with policymakers. So they have this sort of small picture, but also big picture view. And so that makes them really critical constituents, and it gives them really rich insights. So for this project, what we wanted to do was to really foreground their perspectives, really unpack what they see, what they observe in the community about how structural racism and systemic failures impact Black birthing people, and then just understand what they're doing to address the gaps that you're seeing in their community. So we conducted in-depth interviews with 12 community-based organization leaders as well as staff. And then did an analysis of those interviews. So I'm going to be unpacking some of the key insights or highlights that we found from this study. So the first one would be unsurprising to most of us, the systemic failures and structural racism impact Black birthing people at multiple levels. And so we mapped what we heard onto an adapted social ecological model. And what we can see from this is that there's a really dense network of barriers that Black birthing people are faced with as they navigate care and as they navigate access to resources. So we see that at the interpersonal and institutional level, there's prejudice, they experience inequitable care, neighborhood disinvestment, housing and food insecurity, as well as a complex and disjointed benefit system. I'm going to dive deeper into the institutional and community level barriers that the CBOs discussed in the interviews for today. So at the institutional level, CBOs reported disparities in care for Black birthing people. And this often showed up in the interactions that Black birthing people were having with healthcare providers in the presence of CBO staff. But also it showed up in kind of broader institutional practices and cultures. So I'm going to read this quote from a CBO leader in Illinois that I think illustrates this point. Their wishes are disregarded by hospital staff who disregard them as a young Black mom who just surely doesn't know what she's doing, right? And so she doesn't know anything. And they just kind of railroad her into the decisions that they think she should, the kind of birth they think she should have, or what they think she should do without giving her any choices. And that happens frequently. So what we can see here is like a real profound erosion of shared decision-making that compromises the quality of care. And this rises from an interpersonal problem to an institutional problem when these patterns of communication are baked into the broader culture of care within a healthcare setting. And so we categorize this as an institutional issue. Then at the community level, CBOs really discussed the neighborhood disinvestment that Black birthing people are faced with because Black birthing people tended to reside in neighborhoods that just received less investment, right? And so because of that, that impacted the access to resources, the access to care. And I'm going to read another quote that illustrates this. So this frontline worker said, the neighborhoods servicing people of color are on the outskirts of town where transportation is a challenge. So just to come to a central location can require participants to have to either travel far to access the services or just be lucky enough to be so impacted that the community organizations are seeking out their zip codes. And so it becomes kind of like a red lining situation. And we saw a lot of this in terms of just the neighborhoods that people were living in led to these systematic disadvantages that had implications for their access to care and also other programs and resources that they needed. So we know that we also found the CBO strategically work to mitigate this systemic failure. So they don't just observe passively, right? They're actively working in their communities to bridge gaps in access to care and resources. And they do that in a variety of ways. And these are just a few examples from our data about they do a lot of advocacy. They empower Black birthing people to be self-advocates. They provide direct resources and programs, and they leverage partnerships with other organizations as well. However, something that did surprise us was that CBOs are still susceptible to bias. And so even though these organizations are working at the front lines and they're trusted within their communities, they are still embedded within a broader landscape where there are prevalent ideologies that are biased against Black birthing people. And so sometimes they reflected this in the interviews that we had with them. So this quote, for example, and this is notably from a person in a leadership role within the organization, really illustrates this. And they said, I think that African-American women don't get it. It's because they're not responsible, in other words. And I've seen so many that think somebody else should be doing it for them instead of them being responsible enough. And it's like the maturity level of them. And so what we can see from these this study in general is first, CBOs will have really important insights that should be unpacked more and just unpacked more so we can understand what they're seeing day to day on the ground as well as in the broader environment. We can see that they do a lot of really important work to bridge these gaps in access, but we can see that they themselves also need to be sort of accountable and they need to unpack biases that they may have. And in order to make sure that they're not upholding the ideologies that they're fighting against. And this study was funded by the American Heart Association and is currently under review. So thank you so much.
As we move into our grand rounds presentation here, our keynote presentation, I want to introduce Clara Lerma, who's going to be introducing her because many of you know Clara, but in case you don't, she's pretty fabulous, and I want to make sure you know who she is. So Clara is the Associate Director of the Reproductive Equity Action Lab. This is the lab led by Tiffany Green and co-led by Clara. Claire's a mixed methods researcher who's been doing decades of work in domestic and international settings and has recently joined UW, and we're so lucky to have her here. Her strength, and I can really personally attest to this, is building and sustaining interdisciplinary research programs focused on dismantling inequities and expanding access to reproductive autonomy. She's also from Wisconsin originally and has a ceramic cacao collection and spending a lot of time doing ceramics and working on the pottery wheel. So here's Clara to introduce our speaker.
Thank you, Jenny. Hi, y'all. Thank you. I'm so excited to be in person with all of you. As you know, I am frequently remote person, so it's so cool to be here. And last night I had the pleasure of having dinner with our keynote speaker and Dr. Tiffany Green, and it was so lovely. And Dr. Green's very sorry she can't be here to introduce Dr. Karen, but I feel so honored that I get to. Dr. Karen Sheffield-Abdullah is an assistant professor at the School of Nursing at UNC. She's also a researcher, a mindfulness coach, and a thought leader. And I would say she's a teacher and a learner. After what I learned about her last night. So I just want to highlight a few things. We have access to her bio, but I want to highlight things that aren't in her bio. So I just want to say she's on a world tour. She came to us from DC this last weekend where she was inducted as a fellow into the American Academy of Nursing. She was just one of 300 people globally invited for this distinction. And that was on Saturday. So congratulations, Dr. Karen. And then I also just want to highlight that last night while we were talking, I realized that Dr. Karen not only works hard, she plays hard. And so she is so fun. So she's one of us and she has so much fun. And I think you'll see that in her speech today, her talk today, which is an award-winning talk for our MFM colleagues. This was at SMFM and this was presented last year and it was awarded for research excellence for an oral presentation and also received an award for best research on disparities in health. And this is particularly impressive because this is a qualitative body of work. And as you know, MFMs love that quant, which don't we all? We love them both over at Real. And finally, she's going back to school to go get another licensure in mental health. And you'll hear about her passion about that today in her talk. So I'm just very excited to have her here with us today. And please join me in welcoming her.
Okay, can you hear me? Yeah. Good morning. Good morning. Good to see you all. Thank you to, just excited to be here at the University of Wisconsin at Madison with the Department of OBGYN to be the keynote speaker for the Gloria Sarto Health Equity Symposium. So as Clara mentioned, I work hard and I do play hard. I did enjoy last night's dinner at Mint Mark. I think that's where we were. If you haven't been, you should go. It's quite tasty, yummy food. But really wanting to take a moment today to talk to you about the work that I've done with my MFM colleagues who came to me and said, Karen, we really want to learn qualitative research. I'm a mixed methods researcher. I'm heavier on the qualitative side. but really wanting to understand the lived experiences of Black birthing people as it pertains to perceived racism, perceived discrimination, contextualized stress, and also how does that impact or influence their decision-making or their desire for a racially concordant provider? And so my maternal fetal medicine colleagues really wanted to be able to answer that question. And I really am proud of the fact that Dr. Nicole Teal presented this work at SMFM last year. And it was the first time that she had submitted work that was chosen for an oral presentation as opposed to a poster presentation. And she also received 2 awards for this work, and knowing that I was instrumental in helping to not only mentor her in qualitative work, but also really thinking about the importance of mixed methodology. I will tell you that is my bias. I think all research should be mixed methods. I don't think quant can ever tell the full story. It can tell me that, yes, somebody has scored on a particular scale about perceived racism or discrimination or contextualized stress, but it doesn't tell me why. It doesn't tell me the nuances of the lived experiences. And I really think that's where the richness is. So I'm going to talk to you today about exploring Black birthing people's perspectives on racial concordance with their obstetric providers. I was the lead researcher on this. So acknowledging Dr. Nicole Teal, Ariana Day, who was a research assistant, Kayla Blades was also a research assistant in my lab, Kate Menard, who is also a maternal fetal medicine MD at UNC Chapel Hill, and myself, and just also wanting to really talk about our positionality, which is really how we see the world through our lived experience, right? So our research team is diverse and interdisciplinary, positioning us well to explore this question, I believe. We all identify as women, 2 identify as Black African American, 1 identifies Black Afro-Caribbean, that would be me. My parents are from Jamaica. And 2 identify as white North American. 3 of us are mothers, and 2 are part of the LGBTQIA plus community. The senior author, myself, is a PhD certified nurse midwife, mindfulness instructor, and also a mother of 4. I have a 28-year-old, a 25-year-old, a 23-year-old, and a 14-year-old. The authors also include a sociologist, a pre-med student, an MFM fellow, and an MFM attending. Dr. Nicole Teal is now an MFM attending, so out at UC San Diego. So really wanting to understand the background, why is this even important to explore? Understanding that Black birthing people in the US have greater than a 3- to 4-fold increased risk of pregnancy-related mortality than white birthing people. There's minimal published data on ways to improve these disparities in pregnancy outcomes. One viable strategy that we believe may be important is increasing racial concordance between patients and providers. And really also what we know is that a PhD prepared Black woman will have worse pregnancy outcomes than an 8th grade educated white woman. And this has persisted despite decades of work, decades of research. We also know that Black women have twice the rate of preterm birth and low birth weight compared to the global minority or their white counterparts. So why is that? What are we missing? That is the bigger issue that I want us to really be thinking about. And I've really been encouraged this morning with the bright and brilliant speakers, how much qualitative work was being presented. So that really made me feel like, okay, I might be at home with the folks here, that you'll really be able to understand the importance of qualitative work. But before I go into this work even more deeply, I'd like to take a moment just to do a brief moment of self-reflection. I'd like us to just slow down for a moment and really think about what brings you here. What brings you to this work? Why are you interested in obstetrics and gynecology? Who are you, or who do you want to be as a provider? What is it about health equity or equitable work that draws you? What are your biases? We all have them. What are your assumptions about the patients that you serve? How do you want to show up? What kind of provider do you want to be or aspire to be? As I navigate the following slides, I would invite you to listen to learn, not necessarily to respond. Just taking a moment to sit with what is arising as you hear what is being said about the care that Black birthing people are receiving in this country. As a mindfulness instructor, I always like to take a moment just to slow down. Oftentimes we're rushing in, it's early, it's very early, and it's brisk, it's very cold outside. As a North Carolinian, I was just like, okay, Wisconsin, we're a little nippy this morning, but just really taking a moment to think about, we're often rushing to places, right? Where are you in this moment? Your body is physically here. Where is your mind? Are you off thinking about what you were doing this morning before you got here? Are you thinking about what I'm going to say in this presentation? Are you off thinking about where you need to be after this symposium? I would invite you to bring your full self here in this moment and be with whatever is arising. So what we know is that primary care studies have shown racial concordance is associated with higher patient ratings of trust, satisfaction, intention to adhere to treatment plans, and seeking care promptly. In 2020, Greenwood et al. Demonstrated newborn physician racial concordance was associated with Black infant mortality reduction. White birthing people are more likely, obviously, to have racial concordance with their obstetric providers than birthing people of other races. I know as a nurse midwife, I don't know if that was mentioned, but I've been a nurse midwife for 20 years. And I was the director of my own nurse midwifery practice in Connecticut, where I'm from. Born and raised in New Haven, Connecticut, got tired of Connecticut cold and moved to North Carolina in 2009. But really wanting to think about the fact that within the nurse midwifery profession, only 6% of us identify as Black, and less than 1% identify as Indigenous. But if we think about those who are most affected by disparities, right? They are from communities that aren't represented in the providers that are providing care for them. And does that make a difference? There are 2 recent qualitative studies that have concluded Black birthing people prefer racial concordance with their obstetric provider. Ours now adds to this body of work and showing, in fact, that Black birthing people do prefer that racial concordance. There really is very little literature examining Black birthing people's experiences of racism and stress, and how those experiences influence their preference for racial concordance with their obstetric provider. So we're really kind of carving out the gap here of why it's important to even want to look at this. This was a multi-method study with 3 aims. The first aim was a quantitative aim to assess Black birthing people's experiences of racism, discrimination, and contextualized stress. As I mentioned, we used a perceived racism scale, a perceived discrimination scale, and also the Jackson-Hogue-Phillips contextualized stress scale. We chose not to use the Cohen's perceived stress scale, which is a scale that's more commonly used to look at stress. The Jackson-Hogue-Phillips contextualized stress scale is really meant to have more contextualized, nuanced items on it to really pick up on the experiences of stress for minoritized individuals. We wanted to explore Black birthing people's lived experiences with obstetric care and their perspective on racial concordance with their obstetric providers, and that was the qualitative aim. And then we wanted to examine the association between Black birthing people's experiences of racism, discrimination, and stress, and their views on racial concordance. So we wanted to mix the data there. So for inclusion criteria, self-identified Black or African American, 18 years or older, delivered a baby within the UNC healthcare system between 2019 and 2021, and English speaking. So for recruitment, we queried the Carolina Data Warehouse, which is this really giant repository of folks that you can, participants that are potentially eligible. So within all of the UNC healthcare systems, patients are entered into this repository, and we can contact them to be part of a research study unless they opt out. So it's really a large database, and you basically give them the criteria of what you're looking for, and then they just tell you how many people you can access. So we emailed over 3,000 individuals our recruitment materials, inviting them to be part of the study and consented them if they were interested. And consent was performed both electronically within our REDCap and again verbally at the time of the interview. And myself and my research assistant were the two people that did all of the interviews in the focus groups. So we did surveys, as I've mentioned, those 3 surveys, and they completed the demographic questionnaires. And then the estimated time to complete those was 30 minutes, and they were received $15 reimbursement for a Target gift card upon completion. So nominal amount of money for their time. And then the study closed when 200 participants completed the surveys. For the interviews, we purposefully sampled from the 200, right? 15 individuals to do one-on-one semi-structured interviews with us. And we included questions about racial identity, lifetime experiences with racism and discrimination, experiences within the healthcare system during pregnancy, perspectives on racial concordance with obstetric providers. These interviews lasted about 60 to 90 minutes, and they received an additional $25 gift card for their time in doing the interviews. I don't want to jump too far ahead, but one of the things that I did want to mention is that when we were doing these interviews, it's really interesting the way, in my experience over the past decade of doing this work with Black birthing people, how difficult it is to get them to talk about the negative aspects of their experience. They're more likely to want to ingratiate themselves into the healthcare system of like, it wasn't that bad. I was all right. At least I lived. Like people really say that. That is the actual bar. At least I lived. At least I didn't die. That is the real conversation that Black women are having with their partners. If you have to choose between me or the baby, choose the baby, right? And I would talk to them. And then halfway through the interview, I'm realizing it really wasn't all right. It really wasn't okay. Like there was trauma there. And I would reflect back to them. So what I'm hearing you say, and they were like, oh, you know what? I guess it was discrimination. But they don't want to say it in that way. Well, I don't really know what the intent was. I don't really know what they were thinking. I don't want to say that they were, right? I don't want to say that it was actually racism. When in fact, as they're telling the story, it is clearly, explicitly discrimination, racism, and bias. And I will say that at UNC Chapel Hill, at our UNC hospitals, we had recently done a study where we were looking at the ways in which we were assessing pain in Black individuals, and we were abysmal. We were not doing well at all. In fact, we were under-assessing, under-addressing, and under-treating pain in Black birthing people. And so we are really wanting to do better in many ways. So we also did focus groups. So we couldn't just do interviews, right, for qualitative. We decided we wanted to do focus groups as a method. And the reason why I'm interested in focus groups is obviously your research question informs what your methodology and what your methods are, right? So I actually teach qualitative approaches to first-year PhD students. So thinking about the research question. The research question, in my opinion, could really be, could benefit from rich, thick description and interaction amongst the participants, because I think we would get more information if they're talking about their perceived discrimination, racism, and stress together. So that's why we added the focus groups. But because of the sensitivity of the question, it's also really important to be able to have one-on-one interviews with the individual so they can share more vulnerable information if necessary. So after that contextualized stress survey was scored, the 200 participants were divided into four quartiles. And really wanting to represent, we wanted to have representation from those who were the highest stress, the lowest stressed, and those that were kind of in the middle. I wanted to know how would they have conversation when they're the highest stressed group? What were their stressors, right? And what's unique about the lived experiences of those who were the lowest stressed, right? And what about those that were in the middle? And so that was really interesting. And we conducted those interviews or those focus groups, and those lasted 70 to 90 minutes. They were on Zoom. I think one thing that COVID-19 has taught us is that you can do quite a bit on Zoom. Typically with focus groups, you're wanting to do them in person. When you're doing focus groups on Zoom, it's a little bit of a smaller group. So it's only about 4 to 5 people in general. When you're doing focus groups in person, it's more like 10 to 12. But on Zoom, it's a much smaller group so that you can really attend to what is going on with the participants. So with the analyses, the interviews in the focus groups were audio recorded, obviously, and then transcribed verbatim, and the data was de-identified for analysis. Thematic analysis was performed via a standardized process, which includes familiarization with the data, initial coding, searching for themes, reviewing themes, defining and naming the themes, and then the report writing. And so this really was an iterative approach with the team. So the way that that would work is, let's say we have a transcript, I would review the transcript, and another person would review the same transcript. And we would see what codes we came up with, right? And really review those together, and then come to consensus about what we thought the code should be. And then we would have a code book, right, that we developed, and then we would take different transcripts and use the code book to see if we were now using the code book consistently across all the transcripts. And so that's how we came to consensus. So results. So my apologies here, because really what I wanted to be able to show is on the right-hand side, you should have information about the qualitative portion, which is what we're talking about today. But for some reason, it didn't populate within this table. But what I want you to know is that all 32 participants, including the focus groups, and remember we had focus groups and we also had the one-on-one interviews, all 32 individuals in the analysis identified as non-Hispanic Black women. Their mean age was 34, nearly 63% were married, and 72% had a bachelor's degree or higher. Half had less than a bachelor's and half had more than a bachelor's. And participants had a very wide range of income. So sorry that that's not there on the right-hand side, but those are the data. So 16 individuals participated in semi-structured interviews. It's going to be interesting to know why. 5 focus groups were held with about 2 to 4 participants each for a total of 16 individuals. 1 participant showed up for the highest stress quartile focus group. So she agreed to complete an interview because you can't have a focus group with 1 person, right? So, but what's interesting here, what I want to draw your attention to is that the focus group that had 1 person was the highest stressed quartile. So we can think about what are the competing demands and how stressed they are for why they couldn't attend the focus group, right? So thinking about what is it that we could do differently in future studies to be able to somehow get that highest quartile to come and talk to us, right? So we had 5 themes. They are a desire for racially concordant providers, difficulty finding racially concordant providers, not being heard by white providers, stereotyping by white providers and staff, and this fear of dying. And I will tell you, like I said earlier, I've been doing this work for over a decade and talking about stress and anxiety. I'm a stress and anxiety researcher. I think we look at depression quite a bit. I don't think we look at anxiety nearly enough. While many people who are depressed are anxious, not everybody who's anxious is depressed. And the ways in which the Black birthing community talk about their stress and anxiety is very different than the way that the global minority talk about it. And I also don't think that our screeners are culturally relevant for diverse communities to pick up the way we talk about our stress and psychological distress. Right? So we might not say that we're anxious, but we might say people getting on my nerves, I'm irritated, I'm agitated, I got a headache, whatever it might be, but we might not say anxiety itself. And that was borne out in work that I'm not presenting today, but was part of my formative dissertation work. That anxiety is really a thing for Black birthing people. So as we talk about these themes, this desire for racially concordant providers, this particular individual was saying, I was actually a little hesitant to see the providers who were white in the office just because of the discrimination that I've experienced through my lifetime and the discrimination that I see my friends and my family experience, and also the discrimination that you witness on the news and see on the TV. And I think that's really very apropos, if you will, for what we're seeing now. in this country. And this individual also, another individual said, I feel like there's just an innate knowledge and understanding that you would have for someone of the same race. This person said from the focus group, so because I was terrified, and this was my 4th C-section, I told my doctors, because my doctor is a white woman, and I told her, I really would like a Black woman in there because, I'm just afraid. So we're just thinking about the fact that representation matters. Just being able to see someone that looks like you feels protective in some way, right? So she's being explicit in saying, I would like to have a Black person in the room with me. What that takes to be able to advocate in that way for yourself, to actually say those words, right? How fearful you really must be. This other person says, just because of personal feelings and experiences, I would probably refer one of my friends to a doctor who was African American. I really would have loved to have had a couple of Black midwives. I would have loved to have had somebody that looked like me. But remember, right, the percent of Black midwives in the profession is only 6%. So the likelihood of having a Black midwife is really low. And in North Carolina, when I last asked the North Carolina Board of Nursing how many Black midwives there were in North Carolina, there was something like 30. It's not many for an entire state. So again, on this theme number 1, this person said, I can interact with a Black doctor or just a Black professional in general as opposed to a white doctor. I felt more comfortable because I don't have to be so, I don't know, I don't want to say uptight. I can be more relaxed around a Black doctor. We can talk about anything. But you see, she said, I don't want to say uptight, but she really wanted to say uptight, right? So you're seeing how they're kind of working through this mental gymnastics, if you will, of how to say the thing without really saying the thing. And what are we going to do with this work? What are we going to do with the research? What are we going to do with our findings? Even though we reassure them that it's confidential, there's still this kind of waffling a little bit than being explicit for some folks. This other person said, I know I'm in this group on Facebook. It's just like mamas of color, and they ask for African American. They specifically ask for African American doctors. And I can attest to that as somebody who is on Facebook. And I will often see people say, hey, does anybody know of a Black OBGYN that I can go and see? Hey, does anybody know of a Black mental health care provider? And as Clara mentioned, or may not have mentioned, I am going back to school yet again. Why I'm doing that, I don't know, but I do know. I'm really interested in Black perinatal mental health. And I'm really thinking about the ways in which I can have the most impact. And while I am a nurse midwife and I can prescribe and I have some level of comfort prescribing for psychological distress or issues like anxiety or depressive symptoms, once we get into polypharmacy, I really don't feel comfortable managing that. So I've decided for me personally, in order for me to really have a foundation that feels right to me, I'm going back for a postmaster certificate in psych mental health nurse practitioner, which is just 15 months, not just 15 months, but it's a 15-month program. But it will really, I think, help me to feel like I have more in my skill set that makes it amenable to really providing stellar care to the patients that I see. And lastly, for theme 1, then this last labor was a rainbow coalition of people, and I had more Black women involved in the pregnancy and delivery process, and it made so much of a difference that I would say it was definitely mandatory. So this person is talking about a positive experience of having had a lot of people of color in the room for her last labor. I don't have time to talk about the counter narratives for all of these, but I will say that there is a counter narrative. There are Black women who say that they had a Black provider and it was an awful experience, right? So, or that person didn't feel comfortable with their Black provider because of whatever reason. So I don't want to make it seem like this is a monolith, like this is the only narrative that was there, but the majority of the narrative was what I've shared with you in terms of the desire for racially concordant providers. Oh, I have one more quote here. So all of my nurses were Black except for one, and I do feel like it made a difference. You hear about disparities in the treatment with women of color. You hear about an increase of death in women during childbirth. I can only imagine that my nursing team, especially being women of color, they were aware of those statistics. So yes, I definitely think there was some extra attention there. If it weren't for her and her attentiveness and her genuine care and concern, I don't think that outcome could have been the same or would have been the same. I think I could have been near death. And I believe that with this participant, it was, she was postpartum and she was mentioning that her nurse was like, I don't really like your bleeding. I don't really like how much bleeding you're having. And she would assess her and she's like, I'm not crazy about that. So she called out a resident came in, was like, no, I think it's okay. And then left. And then she proceeded to continue to bleed very heavily. And this Black nurse was like, I don't like this at all. So I'm about to press a button. When I press this button, a lot of people are going to come in the room, right? And so she pressed the button. A lot of people came in the room. She ended up having to go to the back for a postpartum hemorrhage. But I think that's her point in saying that having somebody there to advocate for you and say, I just don't like it. Something in her, whatever, spidey senses was like, this isn't right. And she really advocated for her and she felt that. So for theme 2, there was difficulty finding racially concordant providers for obvious reasons, right? I can't speak specifically for the OBGYN population, but I do think that you all are probably similar to midwives in that about maybe 6% or so identify as Black within the OBGYN profession. Does anybody know that statistic? I think that's about right. I think we're about on par similarly with midwives. But the idea is even if you want to have a Black provider, it's really hard to get that. And I know that there have been programs that are really pushing to be able to have pathways to open up for more providers of color. This person talks about the doctor's office that I went to had multiple providers, which 95% of them are white, and I think maybe 3% of them are African American. I don't know what the other 2% was that she was that isn't included here, but she's letting you know that there's very few African American providers for her. This other person talks about there's one Black one that's in that particular practice, and then the rest of them are all white. But the one is not enough, right? One is not enough. I wish there were more. This person said, I was actually trying to find an African American or Black physician doctor that was female, preferably for high risk. Come on now. That was so hard, right? So hard. You want female, African American, and like an MFM? That is super hard to find, right? So she was really having to look. And then this last person said, I just didn't have anybody that actually looked like me. So I was just sitting for a moment to think about what it means to be in a position where many times you're afraid, right? You're scared and you don't have somebody that looks like you. What that experience is like and how that plays into the ways in which our patients, especially our patients of color, show up, right? When I've asked them, what stresses you? Is there anything particularly stressful about pregnancy, right? They tell me. I, as a nurse midwife, have my bias about what I think is stressful about pregnancy. But I also ask them, is there anything particularly stressful about being Black and pregnant? And they told me. And there's a lot there that they hold, right? With judgments and assumptions that are made about them, right? And the fact that there is a mistrust or distrust that is inherent and is steeped in the history of this country. If we just think about Tuskegee Airmen, Henrietta Lacks, right? J. Marion Sims, think about why it is that folks may be hesitant or nervous about coming in to see us as healthcare providers, and then divulging with vulnerability things that they may need help with. This person was saying, I was talking to a white provider and I felt like I was trying to express my concerns, but I felt like she wasn't listening to them. And she was just kind of brushing them off and not taking me seriously. That's a big one, not feeling heard, right? So if anything, the way I started off with that self-reflection as healthcare providers, if we can just take a moment to slow down when we enter that room. Sit down, even if you really don't have time to sit down, and listen with empathy and thinking about all of the social drivers of health. Somebody's got to be somewhere with their beeper. Somebody, it's time to go, right? Really thinking with empathy about how we can provide the most optimal care. I've often, when I do grand rounds, have providers ask me, white providers ask me, so like, Karen, like really, how do we have these conversations? Like what is the way to initiate conversations surrounding stress or psychological distress with our Black patients? One of the things that is really helpful is asking them, is there anything that I need to know about you that will help me provide the best care for you? What do I need to know? Right? Showing up culturally humble. We can't be culturally competent. That's my own bias, my own thought. You can't be competent in another person's culture. I can't be competent in indigenous culture, but I can be humble enough to sit and learn. How can I best provide care for you? And for Black women, when I said, are you having conversations with your healthcare providers about stress? They're like, no. And I said, would you have wanted to? That's another question. And they said, yes, but only if they're going to have the resources to provide for me so that I can get optimal care. And they said, if you want to know what I'm stressed about, ask me what I'm Googling. Think about it. If any of us had our search history looked at, right, we would know what we're thinking about or what we're worrying about. When Black women Google about their outcomes, that's stressing them out, for sure, right? So even if you started there, that's something simple. They said, if you want to know what I'm stressed about, ask me what I'm Googling. This person said, I've run into a lot of white male doctors that clearly were not listening and did not take me seriously. I've run into a lot of female nurses that clearly did not care. Theme 3. I remember feeling very, I'm not heard. Sometimes it's hard. I think as a woman of color, it's hard to know. Is it because she was a newer nurse? Is it because you just don't feel like doing your job? Is it because you don't think I know? One participant had said she had a conversation with her healthcare provider. The healthcare provider excused herself because she needed to go do something, and then she heard her talking about her in the hallway. So now that trust that may have been built while she was in the room is now gone. This person said, I did not feel heard. I did not feel like they were taking me seriously. So you see what theme 3 is, not feeling like you're heard or taken seriously. Theme 4, stereotyping by non-Black providers or staff. The biggest thing that I get a lot is one of those questions that I don't think they mean to be offensive, but it is highly offensive. You see, she's also waffling a little bit. I don't think they mean to be offensive, but it is offensive, right? And that question is, do I know who my son's dad is? I got that a lot when I was pregnant. This also has been seen in my formative doctoral work. A lot of judgments and assumptions about individuals. One participant said she wasn't wearing her wedding ring and she came to her appointment and the provider was like, oh, is the father of the baby not involved? And she was like, my husband's at work, couldn't make it today. But because of swelling in her hand, she couldn't wear her ring. But furthermore, why does it matter? Right? Why does it matter? Doesn't matter if she's married or not. This next person says, she's like, well, abortion is an option, especially if you don't know the dad. I'm just like, wait a minute. I do know who my child's dad is. And then the nurse's response or provider's response was, oh, so y'all actually managed to stay together? Just like, why is it so much of a surprise? I'm sorry, am I meant to be a single mother? So thinking about how these biases show up, right? And then there was this nurse in particular kept coming in and being like, if you're a single mother, you're being abused, let me know, I can call the social worker. I knew in my head, like, you're saying this because of what you think you're seeing, but you're also saying it because we're Black. And she kept asking me, do I need a social worker? Do I need WIC? Do I need all these things? And I'm like, what in my profile is making you ask these questions? Are these normal questions, or are you asking me this because I'm Black? This person knows the answer to that, right? She knows that these questions aren't being asked of every patient on the unit. And she's saying, are you asking this because I'm Black? And this is something that is not uncommon to be asked. And so a lot of times Black birthing people will be hesitant to share any vulnerabilities surrounding their mental health or what their needs may be, for fear that CPS is going to be at the delivery and nobody has told them, right? That CPS is there and they're being evaluated. That has come out in my research as well. And then lastly, this fear of dying. This person who said, I was so scared because I'm like, I might die with this pregnancy. Like, that was the first thing through my head. I could very well die just from simply getting pregnant and because I decided to have a child. Why is that so prevalent, right? Because they have 3 to 4 times the chance, right, of dying due to a pregnancy-related cause. If you keep hearing that over and over and over again, I'm hearing now that people are making sure that they have life insurance. Black women are making sure they have life insurance before they decide to get pregnant, to make sure that if something were to happen to them, their family and their baby would be taken care of. And this person also said, I was definitely concerned about dying in childbirth or afterwards. So imagine navigating an entire pregnancy with the fear of dying. So in conclusion, most participants indicated a clear preference for a racially concordant obstetric provider, citing experiences of discrimination and racism in their lifetimes and during obstetric care as driving factors. Several participants lamented the lack of availability of racially concordant providers. Many participants expressed feeling stereotyped and not being heard during their pregnancy, particularly by non-Black providers and staff members. Lastly, several participants expressed a pervasive fear of dying in childbirth. How many people in here have heard that theme? So a lot of you are already aware of the fact that Black women are just straight afraid of dying, right? So as we're taking care of them, can we just be thinking about that a little bit in the way that they may be showing up, right? And granting them a little bit of grace there, that the way in which they're showing up, there's more to it. And if we can kind of peel back those layers, because they may not explicitly say, I'm afraid of dying, but it's going to show up in a lot of different ways. And then increasing opportunities for racially concordant obstetric care may be one strategy for improving care for Black birthing people. The strengths of this study is that we centered lived experiences of Black perinatal people a priori in the study design. That was something that was very important to me. As we were thinking about the way we were designing the study, I said, Black women's lived experiences have to lead. It can't be an afterthought. Oh, let's look at what they're thinking about. It had to lead there. The qualitative component allowed us to gain a deep understanding of participants' experiences. I've already told you my biases about mixed methods. This is one of the first studies to utilize qual and quant approaches to explore patient-provider racial concordance. The limitations, as you saw, the budget was a little low, right? We only had $40 for each person, $15 for the surveys and $25 for the interviews. So due to budgetary constraints, we could only include 32 participants in the qualitative portion of the study, but I think it would have been lovely to have done some more interviews or even have spent some more time to really try and get that that highest quartile focus group. That would have been really nice, but we didn't have the budget or the time. We had lower than anticipated attendance of participants who scored in that highest quartile, as I mentioned. So what's the call to action? Increase the number of Black obstetric providers. That's just easily said, right? But how do we do that? How do we really think about that, having that impact? Including residents, attendings, midwives, and nurse practitioners. Increase the number of Black nurses and staff in prenatal clinics and on labor and delivery units. Work to eradicate discrimination and racism in obstetric care, specifically in our healthcare systems at large. Explore other strategies to improve obstetric care for Black birthing people receiving care from non-Black providers and staff. So I will say that I am the co-director of a program called Empower, which is to increase the nurse midwifery, the number of nurse midwives addressing health equity, and we've developed a pathway from nursing into nurse midwifery for all individuals, but hopefully we have a diverse cohort. I'm the director, so we do have a diverse cohort of individuals. And so thinking about the different pathways that we can do that across these different professions is definitely important. My references are here, and I always just want to thank my team. Dr. Teal is in the brown pants there. She's fantastic. Really enjoyed working with her as an MFM. And then I have here the rest of my team, Caleb Blades, Ariana Day, Kate Menard is not featured here, and who am I forgetting in the middle? Her name is escaping me in the moment, but this is my team that worked on the project. So very thankful to them, and obviously to our study participants who so selflessly shared with us. So thank you so much for your time. I don't know if we have time for questions. I might have went my full 50 minutes. Yeah. Any questions about any of that? What are these red boxes going around?
They're fancy.
Those are the microphones. Okay.
Can you hear me okay?
All right.
Are you able to hear me? Okay, great. I'm Abby Cutler. I'm an OBGYN in the department. Thank you so much for this amazing talk. I do some qualitative research. And so my question for you is appealing to your expertise as a qualitative researcher, because in some of my work, I have often experienced and struggled with noticing, as you described, like the mental gymnastics going on. And when I am trying to interpret the data and the quotes, and I'm noticing there's something that's not being said, but that I think is being said, how do I disseminate that? Can I create a theme? Is mental gymnastics like a theme that I'm noticing, but how do I stay true to the lived experiences as the participants are expressing in their own words themselves? Is it something that I raise in the discussion? I would just love to hear you talk, because when you said mental gymnastics, I've literally had a code, I call it like a meta code, right? When I'm noticing that in the data, but it's not necessarily something that's coming out like from the participants' own words themselves.
Yeah, thank you for that. So are you the one that's actually doing the interviews, or you have a team doing the interviews and then you're just listening or seeing the transcript? Both.
I'm not always, but I when I'm doing some of the interviews, but this comes up when I'm just analyzing transcripts. Right. Yeah.
When I'm doing the interviews, I actually try to get them to actually say the thing, right? So I might do some more probing or some prompts, or like, tell me more, or can you elaborate, or what I think I heard you say. And that actually helps to elucidate what, like I said, when people will have like this aha moment, that it's safe for them to actually say, I guess that was discrimination, or whatever it might be, right? Or, yeah, I guess now that I think about it, right? So just giving them a moment to pause and providing, I never say you can create a safe space, but creating a brave space for them to be able to show up authentically as who they are. So that's what, like in real time of the data collection, I try to really spend some more time developing that rapport where they can share a little bit more. But most definitely, I have a paper that I'm writing right now where I talk about this juxtaposition of, you can, because even as you're listening to the interview, even if you didn't perform the interview, as you're listening to it and looking at the transcript, you can see a little bit of where that mental where that mental gymnastics is happening. And I think it's absolutely valid to either create a code or put it in the discussion, where you can say, it appears that many of the participants, or a few of the participants, had a difficult time really reconciling what they were feeling versus what they felt comfortable saying, potentially due to social desirability of being in a research study, right? And wanting to please the researcher and not wanting to appear as if they're being too negative. It's really interesting, because when we're learning qualitative, we're kind of trained that, or educated to not give too much like cues, right? But if Black women are sharing very personal, traumatic experiences with you, and you're not giving any feedback, they're going to shut down. They're going to be like, why am I even telling you my business? If you're just going to sit there, and especially for me as a Black researcher with another Black person, right? As they're sharing, if I'm just sitting there kind of stoic, like, thank you for sharing that. That is not going to resonate at all. So I do a lot of, that's really interesting. Thank you so much. I really appreciate that. But, and so it could lead to social desirability, like, oh, I'm giving her what she's wanting. But I think that over time, I've become kind of savvy and sophisticated enough in doing the interviews that I'm not really influencing them in that way. I'm really just cueing for them to please continue on in this authentic way of speaking. But I think putting it in the discussion is absolutely a good place to put it. Yeah, thank you for that. Thank you. Anybody else?
Yeah, hi, good morning. Thank you so much. I'm Ellen Hartenbach. I'm the chair of OBGYN here at Wisconsin, and I really appreciate you coming to share your experience and particularly your research. I do have a specific question. As we work to increase the number of Black providers and other providers from other minority populations for our obstetric workforce, I wonder if there's any experience that you can share or wisdom that you can share that would help us beyond the learning about cultural humility, learning about communication, all those kinds of things. And the reason my question comes up is I'm taking it from my own lived experience as someone of the LGBTQ plus community. When you see the pride flag, it's nonverbal, it's just there. And across the decades, when you see the pride flag, you just feel safer. And I'm just wondering if there's something that could be similar to that. I know we have a limited number of Black obstetrical providers in our department, and I also know that we have a lot of white providers who are really sensitized to this issue and doing everything they can to try and improve these really difficult disparities that everybody's trying to overcome. In Wisconsin, we're still at 3 times the maternal mortality for Black birthing people. So if you could just give us any advice, I'd love to hear.
I love that. I love that. I love the idea of thinking about what would be the equivalent of like a pride flag, you know what I mean? That could be available, that would say, this is a space where we see you, we hear you, you're valued as Black birthing people, right? And women in a way that lets people know that we're here. Beyond, like you said, just increasing the numbers, how do we create that space where people know that, yes, even as white providers, you're in a space where we value this. And I think it's more than, like we have the Black Lives Matter, right? Kind of symbolism, but what could that be for within the obstetric world? I don't have the answer for that, but I would love to think about it and maybe think about it with you, because I think that that could speak volumes. I love that idea. I think that's great. Now you've got me thinking. I don't know. I'll have to maybe ask ChatGPT too to help me think of something that we could come up with, that because that could really be trailblazing, actually, to come up with something like that. So thank you for that. Yeah, I love that.
I think that's all we have time for.
Oh, okay. Okay. Thank you so much. Thank you.
All right, friends, I'm really happy to introduce another gem of our department, Cheryl Casey Grant, an academic specialist who's going to introduce our panel. I just want to highlight Cheryl's decades of experience serving families and birthing folks and pregnant folks here in Dane County. So we're really, really lucky to have her in the department. So she'll introduce our next panel.
Good morning, everyone. It is freezing. So bear with me. I'm always not good with pronouncing names. So if I pronounce your name wrong, I am so sorry. But we're going to start out with our presenter of Tatiana Maida. Oh, good. It's a public health leader and consultant, excuse me, with 20 years of experience advancing equity, racial justice, and system change. As founder of Connexion LLC, and through leadership roles with Health Tide, the University of Wisconsin-Madison, and the 16th Street Community Health Centers, she has consistently centered community leadership in innovative, cultural, grounded interventions that improve health outcomes and drive systems towards equity. Next, we have Janine Dilworth-Bart, is a professor of human development and family studies in the School of Human Ecology at the University of Wisconsin-Madison. She is a 1995 graduate of Hampton University in Hampton, Virginia, and she received her doctorate in psychology from Rutgers University in 2001. Dr. Dilworth-Bart has over 20 years of experience in rigorous home and lab-based research using quantitative and qualitative methodologies, as well as cultural responsive outreach in Black and/or high-risk communities, childcare settings, and schools. Next, we have Amy Minen, is a registered dietitian with formal training in public health. Amy earned a bachelor's degree from Vertebral University in community medical dietetics and a master's in public health from the University of Minnesota. She has spent the last 24 plus years working in the public health prevention field with experience locally and statewide. Amy previously worked for the Ho-Chunk Nation Tribal Health Department with the Wisconsin Department of Health and Services, Nutrition, Physical Activity, and Obesity Program. Currently, Amy is the statewide partnership director for Health Tide, a statewide network that supports healthier communities. Let's give them a warm welcome.
And I forgot how to advance. Let's try this button. Oh, okay. Good morning, everyone. Thank you for the opportunity to come and speak with you today. You don't get to hear me for very long, and that is A-okay, because I want to give space for the meat of this discussion. I'm Janine, and we're going to talk a little bit about valuing the voices of the community. It's great to be here with a group of people who are interested in valuing those voices. And so community conversations is a methodology that Tatiana and Amy brought to me and said, hey, you know what? We really have an opportunity to understand what's happening in our variety of communities here in Wisconsin that typically haven't been heard from or have been heard from in ways that are sort of gate-kept by various and sundry power brokers in the community, and that always has the potential to leave someone out. So the focus here is in amplifying the voices that are often unheard in our communities of color, in our rural communities, in our Native communities, and then mitigating the power dynamic that occurs when a researcher comes in, or that can occur when a researcher comes in and says, hey, tell me all your this personal stuff about your life, and I'll pay you $25. It's a little bit deeper than that. It's also about building trust and being more transparent in what our insights are. And so with that, I want to recognize my position as a university person with power as a university scholar, but not power in other ways. But I want to recognize that and turn the conversation over to my colleagues.
Thanks, Janine. I also am going to spend a minimal time so that you can hear from my colleague, Tatiana. We started this idea in the fall of 2019. Well, it was actually in 2019, we started discussing it. And then by 2020, we were able to hold our first conversation with the Black community. And in particular, we focused on Madison and Milwaukee communities. Those conversations occurred in November of 2020 and March of 2021. So those obviously thinking about the COVID-19 pandemic and the implications that families were experiencing. So we were able to capture a lot of good information. Again, I want to say that the intent of this was really thinking about, as Janine said, traditional power dynamics and how to break them. And so in the conversations that you can see that have happened, we were really intentional of engaging a community person in these conversations. And in the instances of, Tatiana will speak to the latter, but for the Black and tribal community conversations, we utilized a person that was trusted in the community, and then we were able to pay that person to facilitate the conversation. We were not there. And so the conversations were recorded, and then we later worked with the community members to, what I would say, well, we did all of the transcription and everything from the conversation, but then we ended up working with the community members on the dissemination of those results. So what we had done previously is utilized community organizations to get information. And this is, you'll hear from Tatiana, this takes us a step further. This gets, sometimes we think about community-based organizations are serving communities. They have connections to community members. They do. In this instance, we wanted to talk directly with community members. So we'll talk about that. One thing that's really critical in this work is compensating people for their time. And so, as you know, that's been something we've had to really put our heads around of how we're going to compensate them well and how that, what's needed for their full participation. So in order to do this project, we had to really look at a number of funding sources. Janine and I were able to, and Tatiana, we were able to leverage funding from our state Department of Health Services Maternal and Child Health Program. We were able to leverage a grant from the Association of State Public Health Nutritionists, which is a national organization. And then we also applied internally here at UW-Madison, both in the School of Human Ecology. There's a funding source that we were able to leverage, as well as the University Prevention Research Center here on campus. We received a small grant that particularly funded the Latino community conversation. So funding from a variety of sources to accomplish these 3 community conversations. And I'm going to turn it over to Tatiana to hear specifically about the Latino community. Thank you.
Oh, that was me.
Yeah. Okay. Can you hear me better? Okay, great. Okay, thank you. Good morning, everyone. I'm very happy to be here with my colleagues to present this information that we gathered from 5 community conversations conducted in different places in Wisconsin. I have 15 minutes, so I cannot in 15 minutes give you everything, but you will have the links to the full report that has a lot of quotes from what happened during these conversations. Those quotes are powerful. As we saw in the previous presentation, the stories speak more than what we can summarize, right? So I'm gonna share some of the key findings from the conversations, but I just wanna encourage you from now, right now, to go to the links, because that's gonna really tell the story, okay? I wanna start talking about the 2 goals of the Latino conversations. And obviously the first one was, the initial one was to gather data from communities and to understand what are the needs, what are the wants, what can we do? That was one. But one thing that has been always important for me is, as much as we are collecting data, how are we shifting power dynamics in the process? We are evolving in the process of collecting data, and that's gonna probably continue. But there's so much work that needs to happen and better work that needs to happen when collecting data. And one of the things that was very important for me was, how are we elevating community while doing this, and how are we shifting power dynamics with academic institutions and with organizations and elevating the community up. So, that was, I think, I'm going to speak maybe a little bit more about the process, and again, you will have the data about the results maybe on your own. So we wanted to gather data and do that obviously in that cultural responsive way, and I will speak a little bit more about what that meant. But also the second one is that we wanted to work with people from the community for them to facilitate the conversations. As you know, I'm Latina, I speak with accent. I could have done those in Spanish with people, but that was not, because I am, even if I'm Latina, I am wearing my professional hat. So I wanted to do this in a way that would be elevating new leadership, new community leadership in the process, and they can also learn. So in that way, what we did was to shift kind of the model of how to do this work. Normally, you have the institution, it can be academia, then community partner, and then the community at the bottom. That's the normal ladder. In this case, we put community resident leaders at the center of the work, and they were going to be the ones reaching out to communities. And then our role, the UW team, was to help support those leaders, help facilitate those their knowledge and anything that they will need. And then community organizations, they had really, in this case, a minimal role, which it was more like, how can they help us do the administration, the dissemination, some of the recruitment, where are we going to have the conversation? But it was more that administrative and logistical role for them, something that they are normally at the center of the work. So that, I have to say, that required even some internal conversations with my colleagues, because it was like, okay, but they are our partners. How are they going to feel about it? You know, so, and I'm bringing this up because it's important when we want to push shift some power dynamics. Those struggles are real, and we need to have those conversations, and change is never going to be easy, right? So sometimes you lose someone because you're putting the community first. So that was almost like the way how we did this work. We work with 5 community leaders. It took time to get the recruitment of these grassroots leaders, health promoters in the different communities. We had Rosie, who conducted the conversations here in Madison for Spanish-speaking immigrants. And I want to say this also. We wanted to have a multi-language, so we had 4 of the conversations conducted in Spanish for only immigrant parents. And the conversations were in Milwaukee, Madison, Green Bay, and Racine. And these 4 women, they are immigrants themselves. And then we conducted a second generation community conversation with someone who's second generation as well. So there was that, the facilitator had the same level of connection with them, right? And the last, so the second generation conversation was with young parents it was obviously in English, so it was a different dynamic. So we wanted to cover those 2 aspects. I'm going to go quick to some of the issues that came up. And I have to say that when we work with these 5 community leaders, we didn't say, hey, you're going to come and you're going to facilitate this conversation. No, we met with them to create the process. It was a co-creation process where they did instead of us saying, okay, can we talk about these 4 issues? It was like, let's brainstorm. What are the issues that are happening in your communities? We came up with a list of 20. And then from those 20, we decreased to 4, because in one conversation, you cannot cover everything. And then 4 of the topics were these 4: healthy food access, physical activity, mental health, and access to resources. At the same time, each of the community leaders picked a 5th theme that it was important for them in their conversation. So in that way, Racine, for example, covered COVID-19. How was the impact of COVID-19 in families? Green Bay touched in racism. Milwaukee also in racism. And Madison did in, blanking in which one, I don't know if he's in the next one, it's not. But so and then we work in preparing them in trainings, how they are gonna do, we created the agenda. So all the process was co-creation with them, which was a learning process throughout. I have to say also that this is probably the first time that I'm presenting without them, because I'm always making sure that one of them that is co-presenting with me. Key aspects, healthy food. I think it was a number of issues. Obviously, we have these issues. Some of these issues are shared by all moms or dads in the room, maybe. Picky eaters, they don't want to eat. But some of the issues that probably are more relevant for communities of color is the lack of energy, lack of time. When you have 2 jobs, where you are just living in an environment where you are absolutely stressed day after day, when you don't have spaces. So lack of energy is not just lack of knowledge on what to cook. It's like, I don't have the energy, I'm drained. And when I go out, I don't have any healthy options to pick. School meals also obviously came up. Physical activity, it was the car-centric culture that was different than from how it is in Latin America, where you move, you just walk. You're walking 20,000 steps a day, that's the normal. So here the car-centric culture was the biggest issue, and the unsafe streets in different, obviously the more urban places like Milwaukee, that was a big issue, maybe less in other places. Mental health was a big one that came without even bringing up the questions that came up. We know that there is an epidemic of mental health that I think probably most of us are impacted in different levels. But again, in communities of color, we can see that to be really, really high. And mental health in the Latino community is connected with immigration, with discrimination, with the fear of deportation. These conversations were done 3 years ago, 2022. I can imagine that now that fear has just gone up to the sky. So it's a fear that it's not describable. So they spoke a lot about that, and also the stigma around mental health, obviously within the community, that is not. They don't talk openly, and there are not places where to talk, safe places where to speak about that. And then access to resources that they weren't, there are not enough resources that are culturally responsive, that they are linguistically responsive, and that there's not people who look like them. I think there's the same theme that probably you've heard right before this presentation. That's a common denominator, like how can we have a dietitian talking to me, but is someone who's from my community and someone who understands my struggles. So that is just a quick summary. There's so much. I'm just not giving really the right proportion of what was said during that. So that's why if you go to the testimonials, you can get more. We asked them what can happen, what organizations can do, and what you can do. It's a both, right? So it was obviously increase access to healthy foods in different places, in neighborhoods, in schools, develop classes for parents, education, but also local government, how local governments can create incentives with restaurants and fast food places to increase availability of healthy food. If I don't have the time, and even if I know the recipe, where can I eat and get in the taco truck a healthy option, or in the Mexican restaurant, something that is not just French fries for the kids, right? So how the restaurants can be somehow incentivized or pressured to change the environment. In terms of physical activity, obviously more access to free and low-cost options that, again, are culturally responsive. In Latin America, usually we don't know what to do. We don't have snow. We don't have 7 months of cold, right? So when people come here, even me, if I get my kids when they were younger sledding once a year, that was a big thing. That's not something that it's natural for us. We don't know how to dress up. I recently was speaking with families from Afghanistan that in the winter were with sandals because they just not knowing about layers. It's just a different culture, right? So not knowing how to interact with the winter, but if that education comes from someone who is part of your community, then the message resonates. Obviously, also make sure that the staff are culturally and linguistically responsive. Policies that ensure safe streets, that's a big one. People are not safe to bring the kids out. Also, that is cultural, and I want to make a point. I work a lot on safe streets in the city of Milwaukee, and right now we have the Vision Zero plan. I'm part of the committee. I've been working on safe streets for 15 years, and about promoting people biking and walking, okay? However, to me, Milwaukee is not safe to let my kid bike out. So when a good friend of mine is the director of Vision Zero in Milwaukee, and we both have the same age of kids who are now 18. And her son goes everywhere in the bike. And when my son asked me to go everywhere in the bike, I'm not like, no, you're not going. Because I'm working on this and I know the crashes that happen. So you're not going. You can go here, but not there. And my colleague says, you are not doing what you preach, right? But I need to take care of his life. But also it's in my mind. It's a cultural aspect that is in my mind as a parent that I've seen that is different. For example, among my white friends, that they are they promote more independence and I'm more protective. And then add to that the unsafety of the streets. That is a bad combination for more physical activity in children too. So there are many aspects that need to be developed in terms of physical activity for Latino families to start becoming more active. And then mental health, there's a lot there. They really would like to have access to groups that are safe, where they can, like healing circles or retreats, sometimes organized by a church or not, but that those places that have an option that will have childcare, for example, because otherwise they are stuck. They are with the kids. Well, they cannot feel that they can really go to a place and release. Mindful activities. Also, I want to mention, because I'm not going into detail as you will have in the report, the conversations in Green Bay were the toughest for me. I was hearing from Karina the level of racism that was happening in that community, but when I went to that conversation and I heard the mothers speaking, it was insane how we're not talking about just individual discrimination, but a structural racism in the organizations in Green Bay. It was, for example, if I am a US-born Latino going to DMV to get my driver's license, the person is asking me for the social security of my parents. That is something that is not allowed, but that's a practice that is happening there when they look who is asking for the information. In the schools, the teachers were throwing papers to the students, the Latino students. Not just was the bullying that like, oh, we're gonna get the police to get you deported or your parents get deported, not just that, but it was coming from the teachers. Obviously no language support, etc. So Green Bay was a big issue, and so there was a request that parents and immigrant advocacy organizations need to contact authorities to stop discrimination in different places. Again, this was 3 years ago. At this point, with what things have changed, I think things have increased, and the level of power from these organizations probably has decreased for now. And then the last one, access to resources, obviously expand resources, expand places, and also bring people from the communities to lead those programs. I want to go towards some of the conclusions to this. There were, across all the conversations, there were some similar themes. regarding access, regarding what are the specific needs and wants. Obviously, Green Bay racism was higher than in the other communities. Community transformation must be led by lived wisdom and experience of community members themselves. So this is how can we think about not just collecting data and maybe do presentations and what are we doing to use that data? Number one, to shift dynamics of power. Our goal was to do this, use these presentations to go to coalitions that are doing work on the ground, and also the leaders wanted to hold them accountable, come back every year. What did you do? What did you change, right? But also is the process, how we integrate community leaders in our data process. When we did the data collection and data analysis, we realized that using just the normal methodology for qualitative data analysis, we were losing the whole culture and everything that was in these conversations. So we had to redo the first round of data analysis done for students following regular processes. It was like all the Latino, all of us, was like, oh my God, this was not a conversation. This is not reflecting anything that we heard. So we did our own, not our own, we inserted cultural knowledge that can only be inserted by people from the communities, right? I love the phrase that Dr. Karen said before, you cannot become competent in somebody else's culture. That is the thing. You need to bring people from the cultures to do the work. And that's a way, how we are using any opportunity to shift power dynamics. How are we empowering, not empowering, but creating the conditions for people to learn and step into their own power? Compensation is essential. And for that, I think we need to change policies in universities and organizations that sometimes are say, you cannot give more than $20 gift card one time to a person. That is a policy that is not honoring and respecting people, because $20 is doing nothing. And so we were giving $50, but it still was not enough with what we are getting from them, right? So yeah, I think I'm gonna stop there and we can hear some questions. Yeah, that was questions, right? Anyone has any question?
Thank you can you hear me?
Yes.
Thank you so much for speaking today. It's like just really inspiring. I am wondering if you feel like bringing the community members an opportunity to become leaders in their community as a additional benefit, if that's, I'm trying to think like, yes, you're compensating them for their time monetarily, but are you presenting it, or are the community, I forget what you call them, but like community facilitators, are they presenting the opportunity to become leaders as part of that benefit?
Yeah, thank you for your question. I think number one, they were what it took some time to recruit these 5 members was because we were looking for already people who were either health promoters or grassroots leaders. And those are not, there's not a lot of them. It takes time. It took us 4 months. We were delaying the whole process because of that. So we already worked with people who had some level of leadership. It wasn't just some random members of the community. Our goal when we did this was to have a second phase that we haven't been able to do yet, but we wanted to do the implementation. What are we doing with this data with those 5 community leaders, where they could go to communities and again, lead presentations in different coalitions and organizations. So that was the action portion that definitely would increase even more their visibility, their voice, their power, right? Because they are representatives of those communities in a way. So definitely, so there's a learning process. And these 5 members, they all were very grateful because they said that it was the first time that they were connected from someone from academia to a step in a position where they were equal. Just to go through the IRB was a process of learning. I didn't know this. So there's so much information that we can share with communities as equals, not as, oh, maybe they are not going to understand. Maybe they are not going to. So sometimes in my work at the community level, I've seen that sometimes there's a narrative that they are less, I wouldn't say smart, but because they have maybe some conditions, socio-ecological conditions that are limiting them, we might assume that they have less capacity to do certain things. And of course, there's a requirement to adjust. The IRB maybe needs a follow-up conversation. Hey, what did you capture? What was not clear? So speak in more simple terms, but not because they won't get it at the first one, say, no, they won't be able to do it, you know? So, yeah.
Hi, can you hear me?
Yes.
Okay, thank you, Tatiana. My name is Inez, and I guess my question for you is, after gathering all this data and having these community liaisons leading these conversations, what's the next step, for these communities and families to understand, okay, these people heard us, and now what? What are we going to do, or what are they going to do about it? And for them to feel heard, or are these conversations continuing and those connections continuing, so they're not felt like, oh, I let them know something, we shared this experience and these needs, and now nothing. So I guess on your end, what is the outcome, and what's the next step? Action item?
Yeah, I think as I said, our hope is to have the second phase of this work. And this is work in progress, and we're always evolving and seeing what could we have done better, right? And this work took us 2 years because internally we didn't have enough capacity. We had other projects to get the data out right away. So for me, if I would redo things, I will say, okay, I'm gonna prioritize this and get the data out as soon as possible versus being this one more project among other 5. But I think, and so that's why I feel like some of this has been left on the side for now, and because we don't have funding to do the second phase, right now we are in pause. But hopefully we can do that. I know those grassroots leaders will be it will be important for them to do a continuation, because that's the most important part. This data is helpful, but unless there's change at it's been used to make change at a community level, it's just data, right? Oh yeah, thank you, Amy. We've been doing this type of presentation as a way to share the data and with like Amy said, with SNAP agencies across Wisconsin, with MCH. A couple of weeks ago, I did one in Milwaukee with the Milwaukee Food Council. So we have been doing those presentations, but these presentations for now are just sharing the data and see, okay, let's see you do something with it. But if we will do formally a second stage, it will be conducted in a way that is more intentional towards outcomes. So we'll say, hey, what are you planning to do with this? Can we check on you maybe later? Really, change is not going to happen unless there's that accountability, So I think, and that accountability should come from the community, because they have the power and the voice to speak, because they have the experience in the issues. So nobody can speak on behalf of them, right? So, yeah.
Thanks to our amazing panelists and our speakers, as well as the folks who took pictures, dealt with registration, put up the yellow ropes, brought around the microphone cubes. Just really a real team effort here. And I think one thing I will close with is do you all ever have a coworker or someone you get to collaborate with and on a certain shift or in a certain situation, you're like, oh, thank goodness I'm working with that person. Like that is my go-to person. Autumn Hayes is one of the most remarkable coworkers you will ever meet. And it is such a joy and relief to work with someone so competent, but also just it's just a pleasure and to be able to really see how she works and learn from how well she sets up these sorts of situations. And I feel so grateful. So thanks very much, Autumn. Thanks to all of you for coming, and we'll see you next year.